Case 1, excessive hair growth and infertility. History. A 22-year-old woman presents to her GP because she is embarrassed by excessive hair growth on her upper lip, lower abdomen, and thighs. She had waxed her legs and body and shaved her upper lips weekly throughout her teenage years. On direct questioning, she confesses to her period being irregular since menarche and that she is having difficulty conceiving despite regular unprotected sexual intercourse with her partner for the past year. Her family history is significant for diabetes, hypertension in her mother and the maternal grandfather. Examination. Physical examination reveals a mildly obese woman, body mass index BMI being 31 with moderate facial acne and confirms Hirsuitism. Fairman-Gallwey score 15. Examination of the genitalia is unremarkable with a patent outflow tract and no clitomegaly. Bimanual examination reveals a mobile everted uterus. Investigation. FEBC and U plus E is normal. Urine beta HCG negative. Questions suggest a differential diagnosis for the cause of this women hirsuitism. Question 2. Based on the clinical picture, what is the most likely diagnosis and why? What do you know about the etiology of this condition? 3. What further investigation would be useful to confirm likely diagnosis? 4. What are the management options in treating this woman's symptoms and overall condition? Are there long-term health problems that need to be considered in this patient? Medically, Hirsuitism refers to excessive terminal hair growth in a male pattern in women. Up to 5% of women of reproductive age are hirsuite, according to the Fairman-Gallwey scale, which scores hair growth in the most androgen-dependent part of the body, with score greater than 7 define a hirsuite. Asexual hair growth is entirely androgen dependent. Androgen levels and the sensitivity of hair follicles to androgen are primary factors leading to hirsuitism. However, women with milder hirsuitism may not have elevated androgen levels and have what is known as idiopathic hirsuitism, which accounts for around 50% of cases. The remainder of the cases associated with hyperandrogenism, the causes of which are 1. Polycystic ovarian syndrome, 2. Adrenogenital syndromes, for example, non-classic congenital adrenal hyperplasia, 3. Androgen secreting tumors, 4. Other causes of hormone overproduction, such as Cushing syndrome, 5. Drug-induced. In these women, the main presenting complaint of hirsuitism and difficulty conceiving with probable anovulation are consistent with the diagnosis of polycystic ovarian syndrome, PCOS. PCOS affects up to 10% of women of productive age and is the underlying factor in around 15 to 20 of infertility cases. A diagnosis of PCOS according to the 2003 Rotterdam PCOS consensus group can be made with the two of the following three findings. 1. Clinical or biochemical evidence of androgen excess. 2. Oligo or anovulation. 3. polycystic ovarian on ultrasound. The clinical findings in this case are sufficient to meet the first two of these, allowing putative diagnosis of PCOS to be made. While the exact pathophysiology of PCOS is unclear, one theory suggests that increased gonadotropin releasing hormone GnRH pulsing leads to increased luteinizing hormone LH pulsing, stimulating increased production of androgen by Zika cell in the ovary to act synergistically with LH to enhance androgen production by Zika cells. Further, insulin inhibits synthesis of sex hormone binding globin SHBG by liver, thereby increasing the proportion of free testosterone to the blood. These effects of insulin account for hyperandrogenemia in PCOS, which disrupts the normal follicular development process leading to anovulation. Before a diagnosis of PCOS can confidently be made, other conditions that produce hyperandrogenemia and irregular menstrual cycle need to be excluded. Further investigations that may be performed to look for other causes include thyroid function, hypothyroidism, serum prolactin, hyperprolactinemia, 24-hour urinary cortisol Cushing syndrome, morning 17-hydroxyprogesterone levels elevated in non-classic congenital adrenal hyperplasia, oral glucose tolerance tests, and growth hormone suppression, acromegaly, follicle stimulating hormone FSH, and oestradiol high and low normal respectively in premature ovarian failure. Biochemical investigation may show increased testosterone levels, reduced SHBG, increased LH, and high LH-FSH ratio. An ovarian ultrasound should be performed to visualize the ovaries. Management of the PCOS is essentially symptomatic. Hirsuitism and acne are managed by agents designed to inhibit hyperandrogenism, such as the combined oral contraceptive pill and anti-androgens such as cyproterone acetate and spironolactone, and also alpha-nephrine hydrochloride, as well as radon electrolysis for hair removal. The presence of chronic anovulation carries a risk of endometrial hyperplasia and carcinoma, and therefore requires a treatment typically with a contraceptive pill or cyclical progesterones. Ovulation may be included with the use of clomiphene and estrogen receptor antagonist at the hypothalamus. PCOS can also carry a significant risk for development of metabolic and cardiovascular disease, including obesity, impaired glucose tolerance, and diabetes, and accelerated atherosclerosis. The likely pathology behind this is insulin resistance, since women with PCOS are usually hyperinsulinemic. These longer-term complications require similar management to type 2 diabetes with weight reduction and certain anti-diabetic agents, metformin and the zolidones, forming the mainstay of treatment.